wherever your brain decides to go. I'm gonna try to help you pinpoint those words to what condition, so you can start thinking about plans and treatment. So, functions of the liver, we could be here all day. I do not expect you to have all of these to your memory, but I do want you to be aware of what all the liver is responsible for, because when we give medications that affect the liver, or patients that have liver conditions, obviously all of these things are going to be affected. So thinking about somebody who has cirrhosis, over time, for example, they're going to have a decreased ability to have regulation of blood clotting. So it helps with platelet formation and those fibrins, those clotting factors, so that could be affected. We could also have reduction, it produces cholesterol, and who loves cholesterol? The brain loves some fats to function really well, and so if that's inhibited, so that's how you wind up with some of these encephalopathies that we're going to talk about. It's also a filter, so if we knock out our filter or our filter's sick, we have a buildup of ammonia. That's going to be a very common one. We're going to have hepatic encephalopathy that you look at today, and we're going to give a certain drug to treat that. But just get to thinking about it. It helps with clotting, it helps with digestion, metabolism, and it helps with filtration. If you want to summarize all of those things into 3 big words, just to get you thinking. So one more time, so for your clotting, for metabolism, and for filtration. It has many other jobs, the glycogen, so that could be affected if your patient is both diabetic and has cirrhosis. But just keeping it simple as we can, because 500 functions, I don't got time to memorize all of those. So with cirrhosis, what is cirrhosis? Very common condition. That's going to be where you have extensive scarring of the liver that's caused by either necrosis or chronic injury like alcohol abuse. And so what's going to happen over time is those toxins will build up like ammonia. The bilirubin that your liver normally excretes or reabsorbs, however it needs to, is going to result in what skin condition, or change the sclera, jaundice. So we're going to be looking for jaundice. That's sadly a late sign of cirrhosis, but it is an indicator that your patient has some liver impairment. There are 3 different types of cirrhosis. You do not have to know them. I think it is in your prep work. I will not test you specifically, but if you are in your patient's chart and you see that they have post-necrotic cirrhosis or Lennox cirrhosis, you kind of have an idea of what the culprit or causing agent was. So post-necrotic is going to be most of the time caused by viral hepatitis, which all hepatitis are viral, but usually viral hepatitis. And then sometimes medications can cause it as well. But obviously it's in the name. So post-necrotic, what's going to happen? Yep, so it has choked off the blood flow, and so due to lack of blood flow, the liver dies away, resulting in dysfunction of the liver. Then there's Lennox, Laennec apostrophe S. Laennec apostrophe S. When you see that one, alcohol, take it to the bank every single time. Lennox cirrhosis is the most common one in our area. It's what we see the most due to alcohol abuse. And due to the excessive filtration, the liver's like, I quit, I can't keep the alcohol out, I'm done, and it checks out. Then your last one's biliary, and you know from biliary, who's got your biliary duct, or your bile duct? Your gallbladder. And so it is caused by chronic biliary obstruction or chronic gallbladder disease, and so your liver has to pick up the extra slack for the lack of the gallbladder, and it just eats away at it. There are certainly other types, but those are your 3 mains. Hi, Sam.
So when I was working at East 2 years ago, I had a patient who had this type of cirrhosis, and like
the Lennox or the biliary?
It was from alcohol.
The Lennox.
Okay. So we were giving her blood, and it was literally just coming right back out. Give it to her, right back out. She was super yellow. And guess what? She was in the room still drinking. But I said, "You dying?" Well, I mean, she was dying literally, but you know.
That's part of it. The other thing there's a slide coming up with it. We'll circle back and do some more. But just presenting those to you. With the alcohol, there's a certain thing that develops because of cirrhosis called and that's gonna be our biggest culprit there. Bella, shake her head, she's seen nose rupture. She's seen nose rupture in the ER. So things that we're gonna do to promote liver health, liver wellness, if you wanna look at it that way. We're going to try to avoid hepatitis. Can we avoid all hepatitis?
No.
No, but there's vaccines for a couple of them. Which ones do you know vaccines for? I like B, and then there's now oral medication treatment for Hep C, so those are treatable. And B and C are most concerning because they're bloodborne. D only happens if you have type type B. B turns into D. And then your A and E are gonna be like your oral fecal route, so contaminated water, contaminated food sources, things like that. We will study the specifics of hepatitis with inflammation, so you don't have to get into that for now. Just make it mention. Obviously alcohol use, and then things we will do is monitor liver function test. Those would appear on which type of chemistry or which metabolic panel, pulling that back from food and electrolytes. Chem what? Which one? Chem 8. So your basic chemistry or your basic metabolic panel will include your liver functions test. And so, does anybody have a shot at what your liver function tests are? You understand? So now we're gonna give you some letters. So they're gonna be all the A's. So AST, ALT, ALK, or ALK5s, you may see it as ALK and 5s, depending on, you may see it that way. But those are your most common ones, so all of your A's will be your liver functions test. And if those are elevated, or your bilirubin would be another one you can add, but it's not a typical part of the chemistry. We would look at those. And then you always wanna look at your patients that have multiple drugs to take. If all of them are metabolizing in the liver, let's try to give the liver a break, see if we can find a few metabolites through the kidney, through the gut, somewhere else. Give that liver a break. So types of cirrhosis, we already hit those. There's your 3 types. Again, I'm not gonna test you specifically on those different types, but in clinical, if you're reading the history and physical, and you see those, it can kind of tell you if it was a, whoop, they had gallbladder issues a lot, whoops, this alcohol, and whoop, this just breakdown from toxins, or they've had hepatitis, something like that. So things that put them at risk, you got alcohol use, your viral hepatitis, autoimmune hepatitis, we'll do that in inflammation. Steatohepatitis, what's steato a fancy word for? Anybody know that one? All right, or if Mr. Fuller actually has this condition already because I'm a fluffy person, and so this fluffy substance loves to hang around my liver and block it. Okay. Huh? Fatty liver, steatohepatitis, that is fatty liver. Damage to liver by medications or toxins, chronic gallbladder issues, and then cardiac cirrhosis. Not this semester, you can exit off, it's just there because it's in your book. Not even going to talk about that today. Not one of our things. So things that you're going to look for. Per picture perfect patient over here. You're going to have that distended abdomen and mental confusion. Those are your 2 biggest hallmarks, and we'll look at those specifically in a second. But obviously, that's your physical signs. And then if you start looking at this other stuff there. So fatigue, why are they gonna get fatigued? Because what did we say the liver did? So this builds up. Well, not metabolism, but it's what builds up makes you tired. Well, I get you. Okay, maybe you're not even looking at metabolize. I get where you're going now. Good. Okay. Good. Build up of those toxins. All right, weight loss. Again, back to your metabolism. Abdominal pain is going to come from your portal hypertension and distension of the abdomen. Confusion, difficulty from buildup of ammonia. Personality and mentation changes. That typically comes from the buildup of toxins. They don't act as themselves. Then your gastroesophageal bleeding. Esophageal varices. There's a picture coming. But what that is where your portal vein is going to try to have deviations for the buildup of the blood pressure that's built up in that portal vein, creates portal hypertension, and so all down your esophagus, you're going to have those little varices or these little bleeders, where your portal vein's trying to let off excessive pressure. And what happens is when those varices rupture, they're gonna have a GI hemorrhage and they're gonna bleed pretty severe. And then portal hypertension, buildup of pressure into that portal vein that's in your liver. Ascites is the accumulation of fluid in your peritoneal cavity. So when your body can't get rid of it, it just kind of holds on to it and it pushes it out into that peritoneum. So thinking about if you have all this in, so think it's in the lining. It's not just free floating out in the gut, it's in that lining. So how much can that lining really stretch before it starts getting uncomfortable? And so think about all the things that are lined with the peritoneal cavity, so your lungs, so it's cardiac, your heart. So it can start putting increased abdominal pressure on the organs that are in there and creating a whole new set of problems. And so typically they'll have a paracentesis to drain off that excessive fluid. And I'm fired, you know what I did not do?
Record.
I'm fired. I'll go back and add the prefix at the end. I knew I'm like, things are going a little too good. Too easy for a startup. Yes. It is.
You can hear me. I think I just whisper loud.
I can't even whisper.
Chuck, you just say things. I'm right.
And we'll go back and get your little introduction in a bit. Alright, so then, jaundice, obviously yellow. Petechiae is going to be your, little, I call them semi-chicken pox, but they're gonna be these small, pinpoint, focal, bruising. Spider angiomas, those are going to be almost kind of like your, varicose veins, but not really. They're also, they can get large and, fluid filled with blood. But that's again from your buildup of pressure, your body's trying to get rid of fluid and displace it wherever they can. Asterixis is gonna be what they call the liver flap. So if your patient has their extremity held out, their hands literally, and we'll show you the video at the end, it's got the liver flap. And then Fector hepaticus, liver breath, and it's gonna have this, fruity acetone smell, very similar to DKA. I don't know that I'm gonna give you a, scratch or sniff challenge to, what's the difference? Do they have ketones in their breath or do they have Fector hepaticus? But anyway, it's just a hallmark sign that you'll see physically until you get in. Your labs and diagnostics, several mentioned here. We can test anything there. So you've got some liver enzymes, ALT, AST, ALP, ALK. That's the alkaline phosphatase. You'll see it different ways. You can ALP, ALK. Bilirubin, albumin. Remember, albumin was a protein that's in your blood. CBC, because we're worried about clotting. So not only are you going to look at your reds and your hemoglobin, also going to look at your platelets or the PT-INR, see what your clot times are. Ammonia is that liver toxin we're worried about causing encephalopathy. Why are we worried about creatinine with the liver? Because I thought that was a kidney lab.
Isn't it because the liver also does filtration?
Because if your liver's not filtered, who picks up the slack? And so we're making sure our kidneys aren't shutting down because of the extra workload on them. All sorts of diagnostics. We can look at ultrasound, to look at the bile duct, look at the portal vein, all those little geographic landmarks in there. X-rays and CTs to see if there's any masses or anything that's causing impairment. MRI would be for your severe cases. Our liver biopsy is the one that we love because we can test the tissue to see if it's cirrhosis, hepatitis, any other liver condition. EGD, looking down the throat, that would mainly be focused on treating those esophageal varices. They'll go in and try to, cauterize or, clip the bleeders on the esophageal varices. And then an ERCP is an endoscopic retrocoliopancreography, or I'm pronouncing most of that wrong, but it's looking to the backside through, the lining of the esophagus to look at the pancreas and gallbladder, liver structures through there. East Alabama does not have one. If we have to have an ERCP, we send them to Grandview, is the closest one there for that. Here it is, endoscopic retrograde cholangiopancreatography.
Do we have to have that?
ERCP. But if you see that big long word that's got an ERCP, endoscopic retrograde, polio, they're looking, it's EGD mode, but they're looking at liver, pancreas, gallbladder structures instead of the esophagus itself. Maybe, but as of the last time I was there to have a patient with one, we had to send out the Grandview. Maybe they do.
What does EGD stand for?
Esophagogastroduodenoscopy,
These are all scopes.
both down the throat. The fun part with, this is just for extra. Going back to informed consent, you no longer can put the acronyms down for the procedure, so you can't just put the patient having ERCP. So just know you need to Google and put that whole procedure name down. Now, same thing for esophagus, because I couldn't spell esophago. That'd be one bad spelling bee. Esophagogastroduodenoscopy. EGD. Moving on, but just getting you thinking about, if you had a liver patient, these are kind of the things that I would follow in the chart for my liver patient. So some procedures, we named some of them. So paracentesis, that is going to be the one where you inject with a large bore needle into that peritoneal lining and drain off fluid. So go back to fluid electrolytes. What would be a large fluid amount to lose in a small window of time? One to 2 liters is actually significant. You will see paracentesis where they lose 6, 7, 8 plus, I mean, if not more than. What's the largest paracentesis you've seen, Mr. McCartney? I've seen an 8, I think.
8 or 9, yeah.
But, so thinking about that, go ahead, Zach. You got a big one.
We had a 20.
Yeah,
Yeah.
1 So like these people can lose like 20 to 50 pounds, like it's insane. But where I'm getting at with the paracentesis, 1 to 2 liters is known to you as significant. So if they're having 6 to 8 liters pulled at a time, what you gonna watch for? Fluid and electrolyte imbalance, ASAP, because they're, especially with those electrolyte depletion, because they're pulling out entire serous fluid, so it's got all of that stuff in there. So that's a pretty big concern. Your endoscopic variceal ligation. So essentially that's the fancy word for what we were talking about, where they'll do the EGD and they'll treat the esophageal varices. So they'll stop the bleeders. Then endoscopic sclerotherapy, not super common. Trying to think, have I ever seen that? No, I would not focus on that one, but it is in your book. I have not seen that one. Your transjugular intrahepatic corticosystemic shunt. So they're gonna go in where? So transjugular, that's where they go in. Intrahepatic, where do they go into? Corticosystemic, so which vein? The portal vein, and then shunt, and they're gonna get something in there. So say that the hepatic vein has gotten closed off, has deteriorated, something like that. They're literally gonna go in through your jugular and get a stent in there, or a shunt. Also, it can help relieve extra pressure, or if they stent it instead of shunt it, then they will expand it to where it can help get the liver pressure off of there, because that's what hurts the liver, is when you have all that pressure build up in there, you're putting that increased pressure, chokes off the rest of the blood flow, and that's most common for that post-necrotic hepatitis or cirrhosis. Surgical bypass shunting procedures, same deal. Instead of going in through the jugular, they just literally do a puncture from the outside and create the shunt. And then in most cases, they're gonna need a liver transplant. Who is one group that 9 times out of 10 will not qualify for liver transplant? Your alcohol abusers. They have to typically go through some sort of AA program and be so many years sober, and that varies by state, so I'm just kind of snowballing. But they have to participate in a rehab program and be sober for a period of time to be considered. A lot of times, the patients with cirrhosis can't survive long enough to make the transplant list, but those that do could qualify.
Are there rules for that too? Is it like a family member, or is it just their choice? Like, if the
Oh, you're talking about if it was an elective, like with somebody,
or
well,
like if they're an alcoholic, but like their daughter was gonna give them part of their liver, is that still?
a partial liver doesn't always do.
I'm just thinking of like
Yeah. But if you're like, I'm an organ donor and I want my alcoholic dad to have my liver, I guess, I don't know the answer to that. But I just want you to know that the chronic alcohol abuse, they are not transplant candidates immediately, so there's a lot of teaching and coaching that has to go on there to help them qualify for transplant. So due to these procedures, they are all considered surgical procedures because they are invasive. All of those perioperative, that's why we kind of put perioperative in this exam, because it should go, with that. So remember all of those things about your informed consent, if they have questions, what recovery would look like, your malignant hyperthermias, and all those sorts of surgical complications that they have. So there's some examples listed for you, but just kind of revisit those. So if the question might be that you had a liver transplant patient, blah, 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 but it's really a perioperative question. So that's why I was talking about the fun of the semester, it just all builds off of each other. So things we can do, add consults to dietary, because obviously nutrition is going to be crucial. So think about if your liver's impaired, like Natalie was on to, we're gonna have metabolism problems and absorption problems. So we wanna make sure that we are able to get them adequate amount of nutrients so that they don't waste away, especially considering fluid. There might be cases on if they have severe ascites, we will put them on fluid restriction. They don't need any more fluid because it's just gonna worsen their ascites. Social services, so like alcohol abuse or resources of why alcohol abuse is there, Al-Anon. Neurologically, remember we talked about during physical assessment some other times that your neurological change is usually an early indicator that something's going on. So if you have a change in mental status, take a peek at those labs. Hepatic encephalopathy was caused by what toxin? Ammonia, so link that together. Ammonia is gonna be that toxin. Asterixis, which one was that? Liver flap. Asterixis is your liver flap. Fetter hepaticus. Liver breath. All right, so we're watching for fluid balance, especially after paracentesis. So fluid volume excess is what I'm worried about with most of them, because they just hold on to the fluid. Your strict I's and O's, because what goes in needs to come out, and most of the time it will not. So we're watching for weight gain with those daily weights. Ascites, can you think about a way, how would you monitor that their ascites is getting better or getting worse? I'll measure what? I like it. And we need a particular pinpoint, because I don't need to go in there and I measure up here and then Anna measures down here, and then, so what you gonna measure around? Make sure it's dead center. So your navel, umbilicus, however you wanna word it, belly button, is gonna be your focal point for the tape measure. And so if your abdomen is growing, obviously the ascites is getting worse. Then it's probably going to require a fluid or sodium restriction. And then respiratory, we were talking about, because of the buildup in the peritoneal lining, it creates extra pressure for them to, or makes it harder for them to breathe. So we're gonna watch their respiratory status with O2 sats. head of the bed at 30 degrees. Again, there's not really a point that a patient's laying flat yet, right? You'll learn some of those, but nobody's laying flat. Or up chair with legs elevated. Why the legs elevated? Yeah, because we were worried about that fluid buildup, and so we're trying to promote circulation there. Skin, we got jaundice, pruritus, fancy word for what? Pruritus. Nope. Itching. Why are they itching? What's building up? Ammonia and other things, toxins. So you can probably tell stories of your kidney patients doing the same thing, right? They itch all the time because of the buildup of toxins. Your liver patients will do that also.
They love Benadryl.
Now, is Benadryl good for a liver patient? No, because they're systemically dry, even though all the fluid's in their abdomen, so that's usually not a good call. So itching, we'll find some other things for itching. And then they're prone for pressure injuries, like we said, because of the extra fluid buildup, so the skin is easy to break down. Nutrition, we want them to have high carb, high protein, because they'll have a lot of energy expenditure, since the liver is out. And then we're gonna increase the B vitamins, that would be aimed at our alcoholics. That's where a lot of the neurological problems will come from, is the lack of B vitamins. So you'll see those liver patients getting, you've probably heard banana bags, which are those glorified multivitamins. So MVI, is your shortcut for multivitamin. So if it's alcohol related, you're probably gonna add on those last two there, the B vitamins and the multivitamin. And then GI wise, we're looking for their ascites. You're gonna measure the daily abdominal girth at the umbilicus, and then monitor for bleeding. So we're calling your signs and symptoms of GI bleed, and then your labs that would help you there. Some medicines you may give them. So since flu is the problem, we'll give them some diuretics. Throw me a favorite diuretic. What's your favorite?
Furosemide.
Love furosemide. It's very classic all the time. Give me some more. I love it. HCTZ. One more family. I love it. So you can get all of them. So if you've got all those in your back pocket, you're good there on diuretics. Beta blockers. So beta blockers work there in that portal vein to help decrease portal vein hypertension. So your patient might be getting a beta blocker, but they don't have a history of hypertension or anything. They have portal hypertension, and so they're trying to keep those varices from bleeding. And then lactulose is to treat the ammonia levels. And you remember Fuller's joke, I don't always give lactulose, but when I do, it's shift change, because it's going to be a lot, and it's gonna be liquidy, and it's gonna have a very weird smell because of all the ammonia. So, yeah, that's how we're gonna treat them. Education-wise, we wanna do alcohol abstinence. That's the hardest one, because that's most often what leads to cirrhosis. In this part of the world. We're gonna follow that high calorie, high carb, high protein. Now, why does it say low protein? I'm gonna fact check. Because one line said high, I do believe it's high carb, high protein. Diet for cirrhosis. Increased proteins, I'm gonna edit that right now. Because I thought that was correct. Should be high protein on both.